All right, well, I'd like to screen share here if I can figure out how to do this. So what I want to do is really talk about the fact that COVID has revealed a lot of disparities. They were there. I'll show you at least one slide about them, but it has revealed a lot of the disparities. And I want us to think about how do we address these disparities. It's quite clear we have, two different at least two different existences going on in America. And those disparities need to be closed if we're going to live up to our probably one of the most important ideals of the country, equal opportunity. So let's just begin before COVID, looking at life expectancy disparities. So what you have here is the life expectancy of the United States in 2013 and 2014, a little old, but actually the last few years it's gone down. So this is pretty close to the high point. If you look at whites, the third set of bars, you can see about 79 years. On the other hand, if you look at African Americans, the last column, it's 75 years. Well, you might say, well, 4 years, what is that? Let me just put that into context. That average life expectancy difference, if we actually, I'm an oncologist, I don't think David said that, but if we actually cured all of cancer, we would increase the life expectancy in America by 3.3 years, okay? So the gap between blacks and whites is greater than curing all cancers. So, or curing all cancers for blacks. So that tells you something about how big this gap really is. It might look small, you might think it's small, it's really quite large. Similarly, the gap between us and Japan is also about 4 years, and it's also very substantial, not easy to get there. The disparities, as I mentioned, are true in COVID. This happens to be the disparities related to hospitalization in COVID-19, which is an indicator of the seriousness of illness. And you can see that African Americans, 247 hospitalizations per 100,000 population. Whites, about 20% of that. Just a huge, huge disparity. And it's true also for mortality. The mortality rate among African Americans substantially higher than among whites and Hispanics somewhere in between. So as I said, we've had these disparities all the time. We've had them in life expectancy. We've had them now very clearly revealed in COVID. Well, how to understand them and how to understand getting rid of them? Well, it's important to recognize, in my opinion, that healthcare is only part of the answer. The National Academy of Medicine indicated that healthcare is responsible for only 10 to 15% of preventable mortality in the United States. That is going to the doctor, going to the hospital, and all of that stuff, only about 10 or 15% of preventable mortality. Much more important is to focus on social determinants of health. They account for 40 to 60% of preventable mortality. So if you really want to eliminate these disparities, of course, we have to address many things in healthcare, and I don't want to eliminate that or denigrate it. We have to address the fact that there's still a gap in the number of blacks that have insurance versus the number of whites, the access to doctors, the access to hospitals, as we've seen with COVID. But if you really want to address these disparities, the disparities in longevity, but as well the disparities revealed by COVID, you have to look at these social determinants of health. So what are, let me see if I can, what are the social determinants of health? And they go from economics all the way to community and social context. And I'm going to leave the healthcare system out. There are things like employment, income, expenses, wealth. There's also neighborhood and the physical environment. There's housing, transportation, the safety, the availability of parks, the nearness to highways and the particulate pollution that creates. One of the most important social determinants of health is education. We know that the more educated you are, like the audience here, the better your health, the better your longevity. So literacy, language, early childhood education, having a higher education degree, all contribute to better health. Similarly, food. We know that nutrition is a major influence on longevity and health. So we've got some major factors here: eating, the environment, income, education. And so it's really important to understand these factors because they contribute so much more to disparities in the world. Well, how disparate are these? Here is a graphic of the real median household income. So this is real income. It's been corrected for inflation, of different racial groups over time. This source comes from the Census Bureau. And you can see that on a real income basis, there is a very large disparity between whites and African Americans. More than 50%, whites are 50% higher income than African Americans per household, and they're 20% higher than Hispanics. So one of the social determinants of health, income, we have a huge disparity. We also know, by the way, that there's a huge sex disparity on this income as well. Just to go drill down a little further, there's also a big disparity when it comes to food and access to food and supermarkets. So the ability to get fresh fruits and vegetables, to not have packaged and processed foods. I would bet that most of the people here take that for granted. But that's not true in large swaths of the country. If you look at high poverty areas, even within poverty, there is a very big difference between whites and African Americans in terms of their access to supermarkets. So within just the low income area, and then you can see even in low poverty areas, we also have a serious lack of access to food among African Americans. So these social determinants of health have substantial barriers. Well, how do we overcome these disparities in the social determinants of health? What is the best kind of thing we can do? So I want to make two important suggestions in terms of solutions. Basically, we've got these disparities. We know that they're mostly driven by social determinants of health, not driven by the healthcare system. We know that the social determinants of health themselves have big disparities. And so to really erase the health disparities, we have to erase these disparities in the social determinants of health. Well, let me talk about one intervention we had thought through, and it's not this one, and that is when we look at counties and the differences in the longevity in counties, it turns out that one of the major determinants of reducing the disparity in longevity within a county between rich and poor people, for example, is social mobility. Counties that have higher social mobility, that allow poor people to rise up because they have more educational opportunities, better job opportunities, those counties actually have narrower disparities in longevity, in life expectancy. For my nickel, dollar, the most important intervention are childhood interventions. And in particular, if we were trying to think of a social policy that would make the biggest difference in terms of reducing those disparities, it would have to be early childhood interventions, and in particular, home visiting programs that provide parents with a trained educator who provides coaching and guidance about how to support, nurture healthy development in their young children. This is especially important because 40 to 50% of all children are born into poverty. They are Medicaid eligible. Medicaid pays for 40 to 50% of all births, which means that those children are in poverty or just above the poverty line. If you target these home visiting programs, often called nurse-family partnerships, you can make a huge difference. The programs have been shown to reduce the risk of infant death, so we would bring down our infant mortality rate, reduce the need for nutrition and TANF, those are food stamp programs in this group. It leads to lower criminal offenses and substance abuse later in the children. So an early investment, infant years 1 and 2, produces substantial changes in terms of engagement with the criminal justice system, saving us money in terms of jails and prisons and other things. It prevents child abuse and maltreatment by parents, and it increases breastfeeding and immunizations rates, so the health of these children. It also turns out that it produces better educational attainment among these children. They're more ready for school early on. Well, it turns out that this is not just feel-good betterness. It also produces an incredible ROI. So Jim Heckman, a Nobel Prize winner in the Department of Economics at the University of Chicago, has evaluated these programs. Every dollar spent on high-quality birth-to-5 programs for disadvantaged children, typically children born into Medicaid and in poverty, delivers a 13% per annum return on the investment. The programs can have positive effect, as I mentioned, on high school graduation rate, years of education, adult employment, adult income later on, all of the disparities that we have noted that lead to bigger term disparities in health and life expectancy. So if you were to ask me, what's the one thing our healthcare system, our country could do to address the issue of improving wealth, especially for those who are at the bottom rung, and improving the health that has been revealed by COVID, it is invest in these childhood interventions, the nurse-family partnerships and related programs. We would get a huge financial return. This is not a government spending program. This is a government investing program. So I hope that gives you something to think about as we go forward, and we all need to think about how we can bring this kind of thing about. Thank you very much, David.
Zeke, that was really a wonderful start for a conversation titled The Health and Wealth of America. As you implicitly explained, these two things are totally connected. You know, if we get, especially if we intervene in early childhood, it wasn't exactly what I expected you to talk about, but I love you did. And it will dovetail with a lot of other programming in the next couple of days. But here's the key question is, how do we get there? You know, you were in the Obama administration, and you actually consulted with Trump in the early months of his administration when he was claiming to want to improve Obamacare, and you perhaps credulously went there attempting to advise him. I mean, does it require Biden to get elected? First of all, is there any hope we could have this kind of an attitude if Trump remained in office? How about those two questions?
Well, you know, David, I often think that, you know, whether you're a Democrat or a Republican, you sometimes say government has to be run more like a business. And you hear that phrase over and over again. And I often scratch my head, well, if you were being run like a business, you would try to generate an ROI. You would try to create an investment that really generates the biggest ROI. And these early childhood interventions, nurse-family partnerships, really are the biggest ROI you can get. As Heckman has shown, the earlier you intervene, the better your return. And 13% per annum is going to be a whole lot better than almost any other government programs. Unfortunately, we say we should run government like a business, but we don't actually do it, especially when we come to things like investing in young children. I do think that, you know, I know this is on President Biden's checklist and the deep thoughts about it. It turns out this isn't that expensive to do. But I think one of the ways I have thought about actually implementing a program like this is to actually make it a mandatory part of Medicaid, so that when the federal government gives the money out to states, part of that, you know, you can't flip a switch and have it overnight because you need to train and hire these kind of people. But you can mandate that, say, in 3 years, they offer every new birth a early childhood intervention, nurse-family partnership, so that we really do have a structural mechanism to put it into place. And, an analysis by the Center for American Progress, of which I was a part, is that, by year 5 of that, you're actually paying back. Now, you don't pay it back in the program, you pay it back by lower Medicaid costs, lower special education costs, lower criminal justice system costs, lower child abuse costs. But that's the kind of way we really need to begin thinking about it. And I do think that if Vice President Biden does get elected and the Senate does flip, this is a way of actually getting this through.
And after all, Hillary wrote that book called It Takes a Village, and it was implicit in her thinking that this kind of thing was needed.
Yeah.
But that didn't help her get elected, clearly. So let's just quickly go to COVID, because you are such an expert. You've thought about it so much. What is your prognosis from here?
Well, it's funny. It's the same prognosis I've had, which is, so at some point we're going to have a vaccine, not before Election Day, but probably early in 2021. It's not going to be the best vaccine. I think that's important to say. It's going to be a good vaccine, and we'll start distributing it and getting people immunized. But it's going to take the first 9 months of the year, even if we have not just one, but say 2 that we could rely on, because production, distribution, administration, building the public trust, all of those things take time and are a challenge. And I would say that the Trump administration, from what I know, and we've done a study and again published a study on this, just hasn't prepared well. These vaccines, they need to be packed in special glass vials. Not clear we can produce the tens of millions, hundreds of millions of glass vials we need. We'll need a lot of syringes and needles.
You don't see progress underway to just the glass vials enough? Is that what you're
No,
saying?
not there's specialized glass vials. There are really 3 companies that make them, certainly in Europe and the US, and you need to produce hundreds of millions of them. Similarly, syringes and needles. You say, well, we should have. Again, we're going to need hundreds of millions of those things. Just imagine, we have to immunize 250 million Americans. That's with 2 shots. That's 500 million additional needles and syringes, which we hadn't planned on. And they've got to be sterile, et cetera, et cetera. You've got to ship them to the right places. We need people to administer these things. Some of them, like the Pfizer one, vaccine, is expected to require, minus 70 degrees Celsius temperature, a cold chain that is complicated. They're working on it, but it's not going to be trivial. And you're not going to your doctor's office because your doctor's office can't handle minus 70 degrees. So we're going to have a different way of administering the vaccine. I have said for a long time, it's November 2021. We'll really have enough vaccine out there and enough situation to really begin to call it normal. We'll obviously open up various parts of the economy before that, but that's the target.
One of the most well-respected journalistic experts, Donald McNeil, in the Times today wrote a piece you probably saw where he was expressing his unexpected own optimism and saying, it sounds like you're slightly more pessimistic than him. He was saying late spring, early summer, we might be able to distribute vaccines to the entire country. He says we've done a better job than he expected. I don't get that same tone from you.
No, I would say, it'll depend upon which vaccines actually succeed. We're seeing the second challenge related to the adenovirus vaccines, the one that AstraZeneca has and the one that J&J has. It's a different method, the Moderna and the Pfizer approach, different method on the Novavax, and Merck has an even different approach, which is they're looking to try to create an oral vaccine, which would obviously make things much, much easier, and a one-shot deal. So it does depend on which of these vaccines cross the finish line, and they have different production capacities and different challenges in production. Pfizer doesn't have a lot of production experience. J&J has more. J&J thinks they can do 250 million doses per quarter. But again, you know, it's not just the US. There are lots of other countries that are going to be wanting these same vaccines.
Right. Well, I was going to go to the other countries question, since you did write a book, Which Country Has the Best Healthcare? And clearly, compared to pretty much all those other countries, we have done worse.
Yes.
What would you say, on balance, is the reason that other countries have done so much better than we have?
Well, first of all, I think it has little to do with their healthcare system and much to do with two things: political leadership and their public health response. So our main problem, and yesterday we published an article which got covered in CNBC and Bloomberg and other places on looking at the mortality rate from COVID in the United States compared to 18 other rich countries, everything from Australia and Canada and Germany to Italy, Spain, and the other countries that had a very rough time in March and April. If you take out the first rough bit, where we were all sort of struggling and Italy was doing bad and we were doing bad and Spain was doing bad, and you begin on May 7th or May 10th, right? We've had a huge number of excess deaths compared to Italy, compared to Spain, compared to France, compared to the Netherlands. You know, tens of thousands of people who died who didn't have to die. And the main reason is we had political leadership that politicized the public health message, did not follow the public health message. The other countries followed the public health message much more rigorously. Even places like Greece did. And that is the message. You've got to do what, you know, use the tools we have. Italy didn't have a vaccine. Spain didn't have some special treatment we didn't have in the United States. What did the countries do? They took seriously social distancing. Don't go inside. Do your dining and other things outside. Keep groups small, under 20, because we know COVID spreads not 1-to-1-to-1, but super spreading events. 80-90% of people who have COVID never spread to another person. 10%, 20% of people spread, and they cause 80% of the illness. If you keep the number of people you interact with down under 20, we can actually get a handle on this. Okay. Wearing face masks, also very consistent in countries that have done a great job. And we didn't do that. We have not slowly opened. You can see Florida today. You know, we're opening restaurants and bars and everything, really. Just go whole hog fast. You know, it's predictable, very predictable. Right after Thanksgiving, mid-December, right before Christmas, they will have a big rise in cases. Absolutely predictable. Okay. We're going to have to wrap shortly, but one last question. Harry Clark asked, and you referred to the J&J vaccine sudden recent delay with an unexplained illness, and compared that to the AstraZeneca case, which was quite similar. And I guess those two vaccines have chemical similarities. So should that delay be concerning? Or is this just expected in accelerated trials? That's Harry's question. Well, any serious adverse event is concerning. We need to know more. We need to know, were there underlying comorbidities? Did this person in the J&J trial get the vaccine or get the placebo? What actually is the full nature of the severe side effect? We don't know any of that. But I do think the one reassuring thing is we're following up. We're having the scientists, the clinical researchers actually investigate the way it ought to happen. And by the way, this happens a lot in trials. Unexpected things happen, which is why we do trials, why we do safety studies, to make sure that the vaccine's not only effective, but safe. Remember, we're going to put these vaccines in tens or hundreds of millions of people in the United States and hundreds of millions around the world. We do have to be sure that they'll be safe, because those people are going to be healthy. They're not going to be sick. Right. Well, we pivoted to COVID, but I want to thank you for your big picture observation and the revelation, I think, for many of us, or the reinforcement of something that we know, but is not said often enough. And it's really wonderful that you are passionately expounding this view that we've got to intervene with young people the youngest people, in order to really transform our country for the better. And the 13% return is astonishing. If that number is right, there is absolutely no excuse not to do this. Yes,
So
it's
thank
an
you.
investment, not an expenditure. That's, I think, the way we need to think about it.
Right. There's so much more we could discuss, but we got other stuff we're going to move on
Lots of
to.
other people.
Thank you, Zeke. You're the greatest. You kicked us off beautifully.
Thank you. Take care. Enjoy the rest of the meeting.